Okay, good afternoon, everyone, and welcome to the webinar today for Recondition the Nation. This is number 3 in a series of 6. You're all very welcome. Housekeeping, if you can keep your cameras and mics off unless you're presenting or part of the presentation panel, that would be wonderful. And we will be keeping an eye on the chat, so any questions, pop them in the chat, but we'll also have time for questions. So for those, put your hand up. So we're joined today, as I said, to discuss Recondition the Nation. So it's a campaign basically that's to raise awareness really on deconditioning and to share best practice and to promote the testing and embedding of small scale changes. We are incredibly fortunate to be joined by Anne-Marie Riley and by Katie Faulkner today, who are both going to share their experience and their knowledge with us. I'm going to hand over now to Amit Arora, who will introduce Anne-Marie in full. And I just also want to introduce Jennifer Walker and Zoe, who are on the call, and they're both fellow improvement managers with ASIST. So thank you. And Amit, it's over to you for now.
Thank you, Emma, and thank you, Jenny. And thank you to Anne-Marie and Katie. So I'm Amit Arora. I am the Clinical Director for Emergency Care Improvement Support Team, and I'm leading the program to Recondition the Nation. And it is my absolute delight and pleasure to introduce my very dear friend, Anne-Marie Riley. Now, Anne-Marie Riley is an absolute inspiration, and I've known Anne-Marie for about 7-8 years, and when I first met her at the Fab NHS Awards, I couldn't stop hugging her because she was such an inspiration in what she did. For those of you who do not know Anne-Marie, she was a chief nurse at Nottingham, and where she started, or one of the pillars of the NPJ paralysis, and I'm sure you all know about it. But she did not stop at NPJ paralysis because she actually did much more than that, and she classified deconditioning as an harm event, and I think she was the first one to ever do that, and look at where we've come since. So Anne-Marie is an absolute pleasure, and it becomes even more pleasurable because Anne-Marie now works with us at the University Hospital of North Midlands as our chief nurse. So without further ado, I think it's over to Anne-Marie Riley, followed by Katie Faulkner, which we will introduce in a minute. So Anne-Marie, the floor is yours. Thank you for coming.
Oh, thank you, Amit, and you're far too kind. I think somebody lovely in the team was going to manage my slides for me. If they're going to pop up.
I think Jen is in the background just trying to share, Anne-Marie. Just one sec.
No, it's fine. It's if I try and do it, I'll be sharing emails and all sorts. So.
I only have Katie's slides, I'm afraid, so I'm very happy to share them if they can be pinged across.
Somebody got them? Sent them earlier.
If you ping them across to me now, Anne-Marie, I'll share them. I wasn't on the email that you sent them earlier, but I'm very happy to share them.
No, you weren't. You definitely weren't.
But ping them across, I'll share them now.
They've been sent, Jen.
Awesome.
We've got them twice now, sorry.
That's okay. Now we're working out how long it takes for an email to come to East London. Right, I have got it and I am ready to go. 1 second.
Oh, thank you.
Not a problem at all. Let me just get ready to share.
I'll just tell you when to move. There's not many, thankfully.
If you start talking, I will start sharing as soon as I can get it up, which is not. I'm making this look much harder than it needs to be.
Yep. You ready?
Yes. I can't. It popped up and I've lost it again. This is really annoying. So sorry.
Don't worry.
Where's it gone? One second.
This is why I didn't do it.
No, what's weird is it came through and I can't now see the email where it came through on, and I don't know why. I'm so sorry. Here it is. I've got it. Right. Perfect. I'm going to share now. Right.
Gotta love digital.
Right. How are we doing?
Fabulous. It just needs to go on slideshow probably.
I am doing that now when I've got enabled editing on.
Fabulous.
This is why I am not trusted at these kind of things. Is that, there you go.
I can't see it now.
Jen, they're not showing anymore.
Right. Let me put it onto slideshow and then share again. 1 second. I'm going to share again. 1 sec.
It's all right, I'll talk quick.
This is, let me try again. And if not, I might have to do it.
Wonderful, Jen. We can now see them.
Awesome. Thank you.
Thank you, Jenny. Sorry for being a pain.
Not at all.
So, as I said, my name's Anne-Marie. I'm Chief Nurse at UH&M. And the reason for choosing this as an image is I would be surprised as a NHS organisation that we've got very much information at all about the level of deconditioned harm taking a place across all the services, if I'm being honest. And in many areas, actually, we haven't got a really robust plan to be able to understand what is happening. We're relying on some, quite high level data without triangulation doesn't really tell you very much. And why should we be worried about it? If you just move to the next one, is that actually there's a plethora of information that tells us that immobility is just really bad for you. Well, it won't move on, will it, if it's not on slideshow? I don't think. Will it? You have to click it. Yeah. So the level of harm is well documented. If you just go to the next one, and it can affect a broad range of physiological and psychological elements to a person that can, one, not only delay their recovery, but two, actually can affect their mortality in its broadest sense. The harm in many cases can actually be life-changing. If you just go to the next one, so there's, as I said, there's a huge amount of information that goes back probably to about 1940s around the harm caused by immobility. Very early on, a lot of it was around bed rest, because people who were old like me remember bed rest wasn't that unusual, was it? It was a prescribed intervention many years ago. But the harm was noted then in terms of what happens to people when they're not mobile. But ever since then, there's been a steady stream of research that's not just around older, frail people. A lot of the evidence is, but it's all age groups, all sorts of levels of mobility. The evidence is really clear that people who aren't moving in hospital, that's the amount of time they spend in bed and in a chair, isn't that different whether you could walk before you came in and you were completely fit and well, to whether you were slightly impaired and you're a bit older and frailer. And that's probably you come into hospital, people think you've got to just lie still. It doesn't, we're not really give permission to be out and about, moving about. And if you Google an image of a patient in a hospital, it will be somebody in a bed. It won't be somebody dressed, sat out by the chair or walking about a hospital usually. Some of these papers I've tested as a chief nurse as a chief nurse, but as a deputy chief nurse as well, because some of the stats were so stark I couldn't actually believe it was fact. And the one around people losing continence function in particular, I tested that with community matrons, with patients who they knew, and it was absolutely true. Within a day or two of being in hospital, we had changed their function, whether that was they were using commodes, whether they were using pads, whatever it might be, but we had changed their continence function from when they came in. And for me, something like continence function is life-changing, and we don't have any right to do that to people, because that's avoidable. But it's really clear, you come into hospital, within a day or two, you are likely to start losing function. within a week. That can be the difference between just about managing at home, if you were just about managing, to not being able to manage and then not being able to leave home or needing ongoing care. And all the papers come up to very similar conclusions. So taking into account different health systems, taking into account different countries, the evidence is quite clear. So if we move to the next one, I won't go through all the bits because I'm assuming the slides will be shared and you can read it afterwards. My question to people on the call is, what do you use in your own organisations for assurance around mobility and deconditioning harm? And what most people have are charts like this. So we'll be looking at falls, and the one on the left with the falls going down will be seen as good. The one on the right where the falls are going up will be seen as bad. And the bottom one with the readmissions going up will be seen as bad. And actually, without any context, they don't give any assurance at all. So we can make falls go down by not letting people walk, but they'll be deconditioned. And if you don't capture that harm, you won't know that. And the one on the right, which is the conversations I'm having at my own quality committee, is as we change culture and keep people active, actually fall numbers might increase because we might be lowering people to the floor. They're not coming to harm, but it's part of a rehab plan to keep people active. And that shouldn't be seen as negative, because as long as we triangulate that with data that said it was part of a rehab plan, we can see that they were able to get back to their original place of where they lived. We've got commentary around whether they lost function in hospital or not. Actually, that can be a positive sign. And the same for readmissions. If we work really hard, put everything we believe it right in place, and somebody can go home and they manage for a little while, if their circumstances change and they need to come back in, that shouldn't be seen as a failure. So some of the language we use isn't conducive to us actually promoting people to keep active and get home earlier. So I said I've challenged internally at committees around some of the language and not taking one as assurance or not without the robustness of data, and did the same to NHS England as well, in terms of we've got to be careful about having targets that maybe stop people doing the right thing. So it's just food for thought about what people use in their own organisations and how you can be assured by that data or not if you don't have a full suite of information. And then if you move to the next one, I'll just share some of the work that we've been doing at UH&M. So one is just keep having the conversation and being curious. So when people are admitted or they're running through the services, just understand what they were like when they were at home or their place of residence, and be curious about what changes might happen. So if somebody looks to have lost a little bit of function, or they're not moving around as much, or they're just not the same as that initial assessment, just start asking why, because that will allow us to at least have a conversation, understand if there's some mitigation, if they might need some treatment to reverse something that might be causing them to feel slightly off colour or not feeling like they want to move around. But without asking the questions, we can't pick that up early. And again, that triangulation of data so that we're clear what somebody's usual function is, and then we are clear how and when that changes. So over the years, what I have learned is that trying to do this as a campaign doesn't work. So we'll flurry it, we'll have a big campaign about something, and then we take our eye off it and things just slip back into how they were before. So what I've tried to do is build deconditioning as a business as usual activity, as in we are looking for it, we're assessing for it, we're auditing it. So we've built it into our nursing audit process, and most areas will have some sort of audit process they do every month. We've added in, and one of the people who did it for me is on the call, Becky. We built in questions around, has somebody lost mobility function since admission? Have they lost continence function? Have they lost weight? Very, very simple questions. It's just a trigger that we've got an opportunity to intervene here. That if we get negative scores on that, it's built into our award accreditation process. So it matters because it affects overall accreditation potentially. And we're in the process of having discussions currently with the clinical directors about how we build this conversation into the boardroom that happens every day. So who takes an interest that somebody's moved, that they've maintained their function, not the therapist. This is about the whole MDT coming together and understanding, has this person lost function, because everybody who interacts with that patient has an opportunity to mitigate a risk. The education, so we do a session on induction, certainly for our support staff, on deconditioning, simple things to look out for, and that again, that curiosity. We might not expect them to know what to do to intervene, but they will notice if somebody has changed. Just raising that as I've just noticed, you know, Mr. Perry in bed for with a, you know, whatever condition, hasn't moved as much today as he did yesterday. I'm just telling you, is actually again another prompt for us to pick this sort of stuff up very early, and making sure the public have got the right information to know the risk of not moving, and their families knowing that we want to keep people active when they're in hospital and the reasons why. You know, we've had looked in previously around how do you get feedback around this from patients, and I think I had a suggestion once on Twitter around, well, they'll be able to tell if their staff were kind to them or were helpful to them. Well, we kill people with kindness, because we do lots of things for people, don't we? We'll just do this for you because we know you're a bit frail, or whatever the reason it might be, but that might not be the right thing overall, if it means that person loses the little bit of function they've got left. So it's quite difficult to get that sort of assurance from patients. Are we doing the best for them? It's up to us to be their advocates, and we can marry that with patient experience data, but they shouldn't be the ones who are relied on, because they won't necessarily have that in-depth knowledge of what potential harm could happen. You know, that's our role. We also have the elements of what's contributed to a harm event, such as falls or a pressure ulcer. We ask as deconditioning played a role in that. I think that's really important. Capturing things by Datex and decondition is so broad, and it is a bit of a minefield that who reports it, who investigates it, who shuts it down. That's just a really simple way to start asking the questions as deconditioning played a factor in harm events. That won't cause, you know, it's a question you ask at the RCA panel. That's, you know, it's a really easy way to do it. And then also considering, we hear a lot around staffing plays a factor in being able to do this really well. But I would ask how many people report it as a red flag. If you can't give a medication because of poor staffing, we'll raise a red flag or a Datex. How many people do that if we can't get somebody moving? Probably not very many. So we're trying to promote that through that process as well, because if we're recognising it as harm and staffing is contributing to harm, then we should capture that data in the same way. We talk about deconditioning in our quality strategy, and within that we are developing a suite of harm-free care ambitions. And the purpose of these is, one, to raise awareness around deconditioning, but two, to change the language. So a lot of policies will talk around falls or tissue fibre. It's when a harm has happened, and it's how we manage it. These are about being able to promote patients to keep well. So it's a safe mobility ambition. It'll be maintaining continence function ambition. So it's a slight change of language, but the actions are very different. You know, the nuance is really important. So if we focus on preventing falls, it's easy to say, well, we'll stop people moving because that will stop them falling. If the focus is we keep people active and able, I think it's just a different language, and it means that we focus on different actions to be able to achieve it. We've got about 5 of those. 2 have been launched, 2 are in development, and 1 will be a bit later in the year. But they're all part of this deconditioning element of our quality strategy. And then the last thing that we are currently doing, there's a whole heap of things on a to-do list, but the last thing that's in progress at the moment is we want to understand how we have a robust way to set mobility goals and capture that data. So we're working with Johns Hopkins in the US. They have a tool, so we're working with them to introduce that here, and there'll be a piece of research that sits alongside that to understand the impact. Again, it's just as being able to make sure that we are triangulating data and changing culture. So it's a quick run through of what we're doing. The biggest thing is we build it into business as usual. It's just part of it, something we do every day. Just as we would think to give somebody a cup of tea, we're constantly thinking around, are they active? Are they maintaining their usual level of function? So I'll leave it there, but happy to take questions, or if you want to move on, I'll take questions at the end.
Anne-Marie, that was fantastic. Thank you so much. I think what we'll do is we'll take some questions now before we move on to Katie, and then we'll have time for more questions at the end as well. So if people want to put their hands up or pop a question in the chat, I'm looking at hands and Jen is looking at the chat. And if there's nothing for the moment, then that's absolutely fine. We can move on to Katie. Okay, so very pleased to introduce Katie Faulkner. I had the pleasure of having a conversation with Katie last week and touching on some of the really exciting work that she's doing at the moment. So Katie's a physiotherapist by background, and she has a real passion, as you will hear, in supporting and empowering people to live their lives to the best at whatever stage of their life they're at. And having ownership of some of that decision making and autonomy in their care. She's currently working as part of a falls prevention programme in North and Central London Training Hub. And it's a community-based project where Katie works alongside a pharmacist and a registered nurse. So there's an MDT approach, and it's really around promoting mobility and preventing deconditioning. And they take a holistic approach to that. So Katie, over to you, and thank you so much for joining us.
Thanks very much for having me. Bear with me while I just share my screen. Not overly tech savvy, bear with. Can you see the right slides?
Well done, thank you.
Not the ones with my notes on, because that's all the secret stuff.
Perfect.
So, hi everyone. I'm really excited to be here exploring how we can support with reconditioning the nation. So thank you so much for having me, and to Anne-Marie for such a fantastic and inspirational talk. I'll start by explaining just a little bit about the information that I'm sharing, because this is mostly based on my own experience with a little sort of sprinkling of evidence thrown in there. So just for background, I started my journey as a healthcare professional as a carer in a Lancashire care home, and since qualifying as a physiotherapist around 10 years ago, I've worked in intermediate care, community care, adult social care in a dementia village, and then most recently as the team lead physio for older people living with frailty at Barnet Hospital. Then as of December, as Em said, I now work for the North Central London Training Hub on a fixed term contract for the next year, where we'll be supporting this new falls prevention programme. So it combines the use of technology and clinical input to support people living in adult social care to maintain their mobility, prevent deconditioning, whilst identifying and mitigating the risk of falls. So I just really want to share my learning and experience from those projects that I've had in relation to reconditioning the nation. So throughout my career as a physio, I've encountered many barriers to preventing deconditioning and supporting reconditioning. But I think the main one that we can all relate to, and the one that we can make a huge and probably quite immediate difference with, is the fact that we as a society, as a workforce across the NHS and social care, and as individuals, are fearful of risk. And we have a tendency to avoid it where we can. But this means that we've all been conditioned to then provide that perfect storm for the people under our care to deteriorate and decondition. But what do I mean by us being conditioned? Well, conditioning is the process of training or accustoming a person to behave in a certain way or accept certain circumstances. And I don't know about you, but this rings huge bells for me within health and social care. So today, I'd really like to focus on reconditioning our conditioning, which isn't only really important, but it's also quite fun to say. So other than the usual issues that we have with the staffing crisis across health and social care, I've found that there's been sort of three main themes which present themselves as barriers to reconditioning our nation. The first one is that so many staff members don't feel empowered to support mobility for older people or people living with frailty. And it's been really common. Oh,
I'm so sorry to interrupt you. Your slides are now not moving. So I don't know whether you want Jen to take over sharing as she's got a copy of your slide deck, or whether you want to do a refresh.
Yeah, is anything happening now?
I can see your onboarding handbook.
My onboarding handbook? I don't even know what that is. Bear with me.
It's not a problem at all. If you want, Jen's on standby if you need her help.
What I'll do is, oh, how on earth has that come up there? Let me stop sharing my screen. And it's a good job it was nothing dodgy though, isn't it?
Happened to the best of us.
I have nothing dodgy on this computer. Can you see it now?
Spot on. What are the barriers I've seen? I can see.
I have no idea how that happened. Okay, so empowerment. As I was saying, so many staff members don't feel empowered to support mobility for older people or for people living with frailty. And it's been really common throughout my career for healthcare staff to wait for physios to assess a patient before supporting them to get out of bed or sit in the chair or walk to the toilet. So anecdotally speaking, I feel that this is often due to a bias that we project onto older people. So I've been asked to review people so healthcare staff can then support that person and go about their day-to-day life. Even if that person only came into hospital the day before and the day before they were walking with no aids and they've got no injury to suggest that they'd struggle to walk at that point in time. So often when we go to review them, they hop out of bed, no problem, having been told to wait for the physio. But the same thing doesn't happen for younger people. Younger people aren't ever told to wait for the physio unless there's an obvious injury. But the danger of this, as we all know, is that it doesn't take long for deconditioning to occur. We know that it can happen within hours for some older people living with frailty. So waiting for a chronically understaffed workforce of physios to assess the people who are under your care before you get them moving in some form or another is just not viable anymore. So let's talk more about empowerment. As part of the Falls project that I'm currently working on, I've spent some time asking staff from across adult social care how they feel when they're supporting a person who is deemed to be at high risk of falling. And early findings from these conversations show that staff members feel anxious and fearful, and when they're asked why, the themes tend to centre around a fear of litigation, either by the service user's circle of support or their employer, a fear of being blamed by their peers, or a feeling of intense guilt that they have let down a person in their care. And I think that that's something that we can all relate to, because we get a huge sense of self from our roles. It's a huge part of our identity. So if we're perceived either by ourselves or our peers or employers to have done a bad job, it's really difficult to not take that personally. So for all of the above reasons, we tend to stay on the side of caution, which then means that we tend to avoid risk, which again curates that perfect storm for deconditioning. Some other early learning that I'd really like to share with you from these interviews we've been doing is the impact of terminology. Now, we already know the impact of terminology, and people like Brian Dolan and Anne-Marie have done fantastic work and amazing seminars on this topic. But there's some very specific bits I'd really like to share with you. So while scoping, we've been asking staff how they feel when they're talking about falls prevention. And some members of staff feel really confident, but many members of staff have said that it makes them feel anxious, it makes them feel uncomfortable, and it makes them feel scared. But if you compare this to how staff feel when we talk about safer mobility, which is a term completely interchangeable with falls prevention, staff report that they feel confident, they feel happy, and that they feel safe. They've also said it's important for everyone, including staff. So If we invested the training and support for all staff to feel empowered in supporting mobility, we could prevent conditioning and support reconditioning. The other really common theme is education around deconditioning, because everyone, whether it's the public, the staff, the service user, everybody knows the risk of mobilising, which is namely falling and the associated risk with that. But rarely do the public and service users in particular, but often staff from across health and social care, know the risks of deconditioning, which Anne-Marie went through beautifully, so I won't say it again. But this means without that knowledge of the impact of deconditioning, the risk of mobility in their head is far outweighed by the risk of staying all nice and cozy and tucked up in bed. So we've also spent time asking staff how they support people under their care who are deemed to be at high risk of falls. And what struck us, and has been the case in every sector I've ever worked in, is that everyone knows the risk of falling, but they aren't aware of the safety first approach that we place onto the people under our care. So these are some of the answers to the question, how do you support people at high risk of falls? I'd use a wheelchair. This has come up time and time again. Even if that person can walk, staff feel that the person under their care is safer when they're in a wheelchair, which leads to deconditioning. Some staff report that they'd like to have 2 people, and whilst this is completely understandable, it might not actually be necessary if there's the correct moving and handling equipment. Plus, with the staffing crisis the way it is, how often are there 2 people available to support our ever increasingly frail and ageing population? So what happens? That person stays in bed. Some staff feel that their perception of risk is reduced when they can have eyes on that person at all times. So whilst all of the legal paperwork might have been carried out to support this, is that what that person wants? If I was living in a care home, would I want to be put into a lounge for 14 hours of the day, surrounded by noise, other people, a TV sort of blaring out things that I don't want to hear about, and be forced to eat my 3 meals a day in front of people? So as an introverted extrovert, I'd really hate that. And you would be putting all of that onto me so that you feel that I'm safe. And it's at this point that I think it's only right that we explore what we actually mean by safe. So we all agree that older people's time is valuable. And often the people that we're caring for are in the last 1,000 days of their life. So it might be that an intervention that's appropriate for one person would cause someone else to feel agitated, restricted, or unsafe. So to ensure that these last 1,000 days are as meaningful and as enjoyable as possible, anything we do to support someone needs to be really personalised and not just a blanket safety first approach, because we need to address what it means to feel safe. We know that being safe and feeling safe are not the same thing. They're not mutually exclusive. So if you imagine an older person that you're caring for lying on the world's best pressure mattress, and the cot sides are up and their fingers are wrapped around the coorbell and you can see them 24 hours a day, are they safe? Maybe. But do they feel safe? Probably not, because feelings of safety and risk are subjective. So for example, I feel safe when I'm riding my horse, but my partner's terrified of them. He goes scuba diving at night in Egypt and says he feels safe, where I would not. So we accept that younger people are willing to accept varying levels of risk in their life, and we need to respect this in later life too, because if we're really, really honest, we would agree that the restrictions that we place onto older adults under our care for their safety, we would strongly reject for ourselves. So there was a study carried out and cited in there's a fantastic paper called Nothing Ventured, Nothing Gained. It's a best practice guidance released by the Department of Health, and it compared the process of risk appraisal by professionals, family carers, and people living with dementia. Now, they found that the professionals tended to focus on management strategies for the future, and they emphasized like physical risk, like falls. whereas family carers tend to focus on the present, and their focus is on the interpersonal domain of risk, such as like the loss of their partnership role, where people living with dementia appeared most concerned with their biographical domain of risk, which is their loss of self, their loss of identity. So, how do we support older adults to achieve a meaningful and enjoyable life whilst promoting reconditioning and reducing their perception of risk? And the answer to that lies in knowing the people we care for as people and using that meaningful information about them and their lives to clinically reason our decision making. We need to know what makes them happy. We need to know what makes them feel safe. We need to know if they're a natural born risk taker, or if, like me, they prefer to avoid the depths of the Egyptian Ocean at night. So moving on to the third and final theme is accountability, and Anne-Marie did a fantastic job of touching on this and talking about this. So the barrier that we face to preventing deconditioning is that there is always going to be some level of risk involved, because we're encouraging people to move. So there's a risk that they may fall. And a fall is a single tangible event, which means I can be blamed for it. So how do I mitigate that when I'm rushed off my feet and I'm busy and I'm stressed at my place of work? I keep the person I'm caring for in bed, wrapped up, nice and cozy, and then they don't fall. They're safe. So I finish my shift, and then the next staff member comes in and does the same, and the next, until this person who came into my care walking with a frame can all of a sudden no longer even get out of bed on their own. So they eat their food in bed, and then the food goes down the wrong way. Because they've not brushed their teeth, because they haven't walked to the bathroom, they develop a chest infection, because they had suboptimal mouth care. So they become increasingly frail and they need more care. And their life has changed completely in a matter of days. And it was all out of their control and without informed consent of what happens when we don't risk getting out of bed. And who's to blame then? It's everyone, but it's no one, because no one single person is accountable for a person's deconditioning, which then makes it really difficult to prioritize when healthcare staff are accountable for everything else in their roles. So let's now make this real life and imagine that we're caring for someone. I'd like to introduce you to Maggie. Maggie is an 87-year-old lady, and she's living with heart failure and dementia. She's under your care, and she refuses to use her walking stick. She's having multiple falls, usually at around 11 a.m. when she's distressed and she's attempting to leave the premises. So let's explore how we can get to know Maggie and use this information to support our clinical reasoning, to prevent deconditioning and support reconditioning. But starting these conversations is really hard. So here's some good openers for leaving the door ajar for these conversations. Things like, what are the things that are important to you? What would you like to achieve as a result of this support? And when you have a good day, what makes it good? So we asked Maggie and her circle of support all of these questions, and let's get to know Maggie's life story. So Maggie's grandson shared that his nana has a unique sense of style and collects antiques. She has a walking stick handed down from her grandfather, but they're keeping this safe at home at the minute for fear it might go missing. Her daughter, Debbie, shared that her mother used to really enjoy walking her dog on the beach, and she'd get up early every morning to walk the dog before going into work as a dinner lady. She was never one to sleep in. Maggie tells you that she'd love to stay and chat, but she'd hate to be late for work, so she needs to get going. So by providing the time and space for candid and open conversation with Maggie and the people who love her, we establish what matters to them. We know that Maggie married her husband, Tony, when she was 22, but he unfortunately passed 2 years ago. She worked for 40 years as a dinner lady in the local primary school, and during retirement walked her dog on the beach for 6 miles every day. Her daughter describes Maggie as lovely and fiercely independent, and she showed you a picture of her riding her granddaughter's horse, aged 72, and told you about the heart operation she had 3 years ago, only to be found dragging concrete bird baths around her garden 2 days later against medical advice. But how does this help us with reconditioning and preventing deconditioning? Well, we now know that Maggie enjoyed an active life. She accepted a certain level of risk, and we can incorporate this into her care plan, any documentation that we do, any risk assessments that we do. The MDT can support Maggie to maintain her mobility, her independence, strength and balance, which will prevent falls and promote joy and overall well-being. We can use what we now know about Maggie's views on life to help us discuss care with her circle of support so that they feel supported in making risk-positive decisions. We can help them understand that although it may prevent falls by keeping Maggie in bed, she'd risk pressure sores, chest infections, cognitive decline. So not only is this restrictive and therefore not in accordance with the Mental Capacity Act, with what we now know about Maggie, it would be really highly unlikely to be her choice. So as I said, the Department of Health released this fantastic best practice guidance called Nothing Ventured, Nothing Gained. And it advises, when it comes to making risk positive decisions about people, that we identify and mitigate risks in a meaningful way for that person. We ensure that there's a reasonable contingency plan in place in line with that person's wishes. We use the person and their circle of support with shared decision making. And I would also add to consider the impact of no action taking place. So during our conversation about accountability, we discussed that no one's accountable for harm caused by deconditioning. So we need to accept that leaving a person in bed is actually still an active decision that has been made, even though there's been no action taken. So let's use all of this information to look at how Maggie's documentation could look. Obviously, I can't change the paperwork and documentation process local to you. So just here's some ways that we could word things to do with what we found out about Maggie. So we could say that Maggie becomes distressed in the mid-morning, which often leads to a fall. At present, staff tried to advise Maggie to stay in bed to prevent her from falling. We've discussed this with Maggie and her circle of support. Her distress is likely due to her cognitive impairment, as she feels she needs to be at her previous place of work as a dinner lady, and she hates to be late. She's always enjoyed an active lifestyle and accepted the risk of injury as part of that. The shared decision is that we will try to reassure Maggie that she's safe and she doesn't need to be in work today. But if Maggie disagrees, we will not cause distress by invalidating her reality. Instead, we will support Maggie to walk to the dining room and support staff with tasks that she can manage, for example, sorting napkins and cutlery, so things that are meaningful to her and her previous role. We'll support Maggie to walk to the dining room. The staff and her circle of support acknowledge that there is a risk Maggie will fall, potentially causing injury and distress. The risk of not supporting Maggie to walk is that she will decondition and lose her mobility, which has always been very important to her. We will mitigate that risk by encouraging her to wear supportive shoes and to use her antique walking stick because she doesn't like the one that was given to her by the NHS. If Maggie were to have a fall, her circle of support would like to be informed. If there are no serious injuries, they would like to support in deciding whether Maggie should be conveyed to hospital as she finds this distressing. So this takes us to a place, where Maggie was anxious, she was distressed and constantly being told to go to bed or sit in a chair with stressed and anxious carers and a circle of support who were unhappy, to a place where staff have the freedom and the support to engage Maggie in activities that are meaningful to her, which will promote her overall well-being and avoid deconditioning and all that comes with that. So it's an absolutely joyous outcome. So to summarise, my findings and my experience over the last few years have been that the fear of litigation, blame and guilt is very real, and we can all be leaders and support each other in that. Developing a risk-positive culture requires constant investment in staff training to help them feel empowered in making shared decisions. Risk-positive terminology is an unbelievably powerful tool. Asking what matters to people is a real skill, and it requires practice. So start now if you aren't doing this already, because knowing the life stories of the people that we care for aren't just nice to know. They help us to formulate meaningful documentation, which can be the difference in somebody deconditioning or reconditioning. So I think that if we were able to champion all of this, never again would we hear the phrase, I'm not getting them out of bed, I've got a pin to protect. So here's the references, and I've spoken a lot about the early findings from the work that we're doing at the North Central London Training Hub, and the team and I would love to share this work as it's an ongoing project with anyone who's interested. And so do get in touch if you'd like to know more. But thank you so much for listening. I really appreciate everyone being here today.
And Katie, we really appreciate you being here. Thank you so much. That was engaging and inspirational and totally patient-centered. And I must say, I feel really uplifted.
Oh.
You know, it's really, really special. And I especially relate to the part you were saying about fear, because we've all been there ourselves, and we've all heard colleagues say, I need to look after my pin, it's my pin at risk. And there's something about switching that mentality, isn't there, to actually a full understanding of harm and therefore what's best for the patient. And I also find it fabulous that you had the same theme as Anne-Marie around language and what the difference is and how you can change people's mindset by the different words you use, you know. So and that falls are bad, but actually the danger's on the other side as well. So absolutely wonderful. Thank you so much. We will now open again to the floor for any questions. Now these can be either for Katie or for Anne-Marie. It's hands up or shout out. I don't mind which one. Jen.
This is a question for either. The conversation about falls and punitive, because the kind of punitive nature around falls is tricky. Any advice on kind of how do we encourage a culture where we explore falls, the reason why they happened? I know, Anne-Marie, you touched on it, and I know, Katie, you were touching on it, kind of in organisations to promote. Obviously, falls with harm are very scary, but how do we promote a kind of more constructive and open communication about falls, and how they may be as a result of trying to do the best thing by patients?
I don't know who wants to pick that up. I'm happy with either of you. Katie, you look like you're there.
Oh, I was going to ask Anne-Marie if she had anything to say before I start waffling.
No, you go first and then I'll come in after you. It's fine.
I mean, Anne-Marie's presentation was fantastic for that. She had so many ideas and is doing so much amazing work to do with it. I think that something that would be really powerful would be to do some co-production with people who have lived experience of deconditioning, and bring, as Anne-Marie said, I don't think campaigns work with this. It's an ongoing, it will be an ongoing process, but to certainly do some work with people who have lived experience of deconditioning and maybe look at the overall impact of that on their life versus, this, as you were saying, this person was lowered to the ground during a rehab session. What's the outcome of that versus the outcome of not doing that?
I think the only thing to add is, so we talk a lot in our committees around deconditioning, and if you ever listened into one of our boards, our chair will talk about the harm of deconditioning. So it's normalising the language and people understanding what that risk is. If it's something nobody ever talks about, it's not going to be seen as, it's a bit like, what you look at is a priority, isn't it? And it's absolutely a priority for us that we prevent harm happening. And I use that term, I use it as harm because that's what we cause. So that balance of staff, absolutely. When we went all over the place when I was working with Brian and Pete and Tim on MPJ Pro. So we talked to lots of different people, and that risk of people falling came up every single session we did, without a doubt. So it absolutely resonates with what Katie has said. But there's no consequence for causing deconditioning harm. There's a perceived consequence to people falling. So I think we have to give deconditioning harm the same platform as we do any other harm, because then you can look at it in the round of other harms. And if you were doing, as Katie said, if you're looking at where the biggest risk is, if you leave somebody in bed, they absolutely will fall at some point because we've deconditioned them. if we do the other things, they might either gain or regain strength and be less at risk of falling. But you have to talk about it in the realms of overall harm and do that risk assessment. And we've got to just get comfortable talking about it. Up until very recently, we didn't talk about deconditioning harm.
Mm.
So, you know, it's in a lot of areas, it's still relatively new.
I think that having people like Anne-Marie, who is, you know, very, very senior, having people like you talking about this and explaining that, you know, it's just as harmful to have deconditioning, if not more harmful than some falls, to know that there's not going to be that sort of comeuppance or that fear of litigation if somebody has gone about it in the right way, if somebody has, you know, done their research, understands the risk and has made that shared decision with whoever it is that they're caring for, whether that be in the NHS or social care, to know that there are leaders in this must be really reassuring. So I think that that's really fabulous.
Lovely, Katie, thank you. Now, Caroline, you had your hand up and it went down again, so I don't know if you would like to ask something.
Some of the questions was the same as what the person before had asked me, but what I did want to add was, which I thought was really interesting, was the care plans obviously have to be so robust, you know, and because within this trust, we do actions after, like most places, we do it after the fact, you know, and we do put things in place to try and mitigate these circumstances when they come in. But what I thought, how you described yours and how they were written were absolutely amazing. And when you hear it out loud, it just makes such common sense that sometimes I think our nurses we're squashed for time, we're squashed to do stuff, and to sit down there, I mean, and try and do that type of standard is so difficult because we work from set paperwork. So as much as I loved it and I would love to put it in place, it's the time mitigation. But the fact that you brought it to my attention is enough for me to go back to my staff and say, let's personalise, let's make it a little bit better. So thank you for sharing that with us. So.
Thank you, Caroline. Anne-Marie?
Yeah, what I'd say as well, Caroline, is there's nothing stopping the patient and their family being really clear what they want to happen to them, and them having some control in terms of what's written. We're so antiquated in some of the way that we do things, aren't we? And it's custom and habit. It's not for any legal reasons. Or, you know, we could do that assessment in terms of what's important to a family. They could co-produce that, couldn't they? It doesn't need necessarily to be completely the nurse. And
yes.
That's without changing your paperwork. You know, it's just us thinking differently, I think.
I mean, I totally agree with you, because we would never think to discharge somebody without chatting to their relatives, you know. So, you know, and if we do that part at the beginning and add it in, and we do to a certain extent, you know, because we have to ask about pre-morbid states and stuff like that. So, so it is there, but for me, it felt as if I thought, oh, I've got so much work to do. This was amazing. This is fantastic. You know, but like you say, we've got an apprentice who can help if we've got our dementia patients and stuff like that. So just all the little people adding something in leads to something quite big. So thank you for opening my eyes and refreshing. Thank you.
Wonderful. And now, Fiona, you've got your hand up.
I was just going to say a piece of work we're doing in the Midlands is actually looking at patients who fall in the community and thinking of deconditioning prior to patients getting to hospital, and do they need to be conveyed or not. So what we're doing is we're working with clinicians and the ambulance service, developing what we hope is either protocol or guidance, looking at patients who've fallen. Do they need to be conveyed? Will going to hospital actually add value for them? Bearing in mind that residents in nursing homes don't always want it. And when you talk to managers in nursing homes, patients are coming back deconditioned and the visit actually has an added value. So we're doing a piece of work at the moment, working with local nursing homes, clinicians, ambulance services, trying to develop some sort of protocol prior to next winter to prevent as many patients being conveyed that don't need to be. And this links with another piece of work we're doing in the region about reducing harm caused by poor sort of UEC flow, and we've developed a community of practice for that. So we're looking at it from a different perspective.
That's fantastic work, Fiona. I love the way at these webinars we sort of learn that there's amazing things going on all over the country that we don't normally bring together. So it's just a meeting of great minds, myself excluded. Anne-Marie, do you have your hand up, or is that a legacy?
Sorry, I'm loitering.
Are you loitering? That's all right. Now we've got 3 minutes left. If anyone else has got a question, I mean, I could actually continue this conversation all afternoon, but unfortunately we can't do that. Nothing pressing. And Jen, there's nothing in the chat that's come through that I've missed that you can see, is there? Oh, Katie's got her hand up. Jen will have a look at the chat while Katie...
No, there's no questions in the chat, but there has been quite a lot of information shared. And could I just stress Amit's sharing, please share your examples, your case studies, your good work, because all the good work that you share then helps somebody else to make a difference. So the more, it's not, the medals are brilliant, but it's more about the difference that you're making that other people could think about. So it's all in the chat.
Brilliant. Katie, was there something else you wanted to bring in there at the end?
I was just going to follow up on what Caroline was saying about, I completely relate to the difficulties and the barriers in terms of staffing, having the time and the headspace to ask these questions when you're burnt out and you're stressed, asking people what matters to them. You just want to scream and say, does anyone care what matters to me? But actually, if you're able to in any sort of way, it does eventually become a sort of invest to save initiative, because then you've got people who are more mobile on your ward, who are taking up less of your time. So you're able to spend more meaningful time with the people who require your care. So much easier said than done. I completely get that. Like, I understand, I really do, I promise. But yeah, I just wanted to share that before.
Thank you, Katie.
Could I just ask, you brought up a government website. I think this is for Katie. Katie, I think you brought up a government website, which was, it was such an easy title that I couldn't remember it. I'm sorry.
I can share it in the chat.
That would be fantastic. Thank you.
Wonderful. Amit, have you anything you'd like to say before we close for today and I do the plug for the next one?
Thank you, Emma. It's just absolutely amazing listening to Anne-Marie as well as Katie and Fiona and so on. I think the only other thing which I would want to highlight is that one of the key things of the aims of Recondition the Nation is not just about improving patient outcomes and health of the nation, but is also about improving staff morale, because every day our staff goes home with a degree of moral injuries because they want to come and do the best they can, and at times they probably feel that, well, maybe they could have done a bit more. Having said that, they've done everything they could, and I think there's a lot in there to improve that staff well-being, especially in these very, very difficult times. So have a think. Yes, think about patients, but also think about our own staff, our colleagues, how we can improve their well-being, and Recondition the Nation also delivers part of that. So, but thank you very much for all that you do.
Thank you, Amit, and thank you for everyone that's joined the call today. Now, our next webinar will be on the 9th of March, when we'll have another 2 fantastic speakers. There are links in the chat to all sorts of great resources. Please do engage with Recondition the Nation. Let's socialise it. Let's get power behind it and carry it forward, because we know it's the right thing. So thank you very much. I've run over by 1 minute. Have a really good afternoon, everyone, and take care.